Dear students, I welcome all of you to this discussion of dermatology questions which appeared in the NEET-PG 2025 examination. These were the questions from where the dermatology questions were asked. Number 1, Papulosquamous disease. 1 question from Vesiculobullous disease. 3 from the topic of infections. 1 from Pigmentary disease. 1 each from nutrition, Genodermatoses and STI, and few overlap topics. Let's begin with the first question from Papulosquamous disorders. A female presented with patches in the oral cavity with complaints of burning sensation after taking a drug for 6 months. Symptoms worsened on eating spicy food. Which drug is most likely to cause this condition? Now, when we look at this image here, what do we see? We see a reticular pattern which is seen in the oral cavity. And apart from this, what do we see is we see some erosions. So because of these erosions in the oral cavity, what is happening? You're getting burning sensation. And this is worsened by eating spicy food. So what is the diagnosis here? The diagnosis here is oral lichen planus. So this is a patient with oral lichen planus. Now, which is the most common drug which triggers oral lichen planus out of the options given here? The correct answer for this question is option number A, beta blockers. Now, when we look at the triggers of lichen planus, number 1, we have dental amalgam. In dental amalgam, we are talking about mercury. In infections, the most important infection which can trigger lichen planus is hepatitis C virus. And apart from this, we have a lot of drugs which can trigger lichen planus. Now, drug-induced lichen planus is also referred to as lichenoid drug eruption. So this is something which we need to keep in mind. What are the different causes of lichenoid drug eruption? Let us classify them into 5 important groups. Number 1, we have antihypertensives. Number 2, antiarrhythmics. Number 3, diuretics. Number 4, anti-malarials. And number 5, metals. Under antihypertensives, we have 3 important drugs. Number 1, AC inhibitors, beta blockers, and alpha-methyl-dopa. Under antiarrhythmics, we have quinidine. Under diuretics, this thiazide group of diuretics. And the anti-malarials, we have chloroquine and hydroxychloroquine. Under metals, we need to remember gold salts. So what was asked in this exam is beta blockers. Other drugs become potential questions for the future exam. Let's take up the next topic of vesiculobullous disease. A 45-year-old male presented with complaints of a pruritic rash over the elbows, knees, and buttocks. He recently visited the gastroenterology OPD and was found to be sensitive to gluten. Skin biopsy is showing IgA immunofluorescence. What is the most likely diagnosis? A. Epidermolysis bullosa, B. Bullous pemphigoid, C. Pemphigus vulgaris, and D. Dermatitis herpetiformis. The easiest way to answer this question, students, is if we would consider epidermolysis bullosa acquisita, which is an autoimmune condition, all these first 3 options, that is EBA, Bullous pemphigoid, and Pemphigus vulgaris, all are IgG-mediated disorders. If the question is only epidermolysis bullosa, it is mechanobullous, so it is not immunoglobulin mediated. So when all these are IgG mediated, the only disease which is IgA mediated is dermatitis herpetiformis. Now, dermatitis herpetiformis, also known as During's disease, is a chronic pruritic disease. It is characterized by a subepidermal split and it is immunobullous. So when I say immunobullous, there are autoantibodies which are going to target the epidermal transglutaminase 3. So this is the antigen that we need to keep in mind. Now, further looking at the disease, gluten-sensitive enteropathy is very important because gluten becomes a trigger for this condition. And apart from this, please remember 2 important HLAs here, HLA-DQ2 and HLA-DQ8. Now, how does the patient clinically present? So usually these patients are in the age group of 20 to 40 years. And how does the patient present? You have grouped intensely pruritic papullovesicles, and these intensely pruritic grouped papullovesicles are predominantly distributed over the extensor aspects of the body. So it can involve the back of the scalp, you have the elbows, knees, and the buttocks. When you do a direct immunofluorescence, what are we going to find? We're going to find the IgA deposition, not only along the basement membrane zone, you're also going to find them in the dermal papilla, and this characteristic distribution pattern is referred to as granular pattern. Please remember, students, in bullous pemphigoid, we are going to have a linear pattern along the basement membrane zone. This is going to go in favor of bullous pemphigoid. Granular IgA is going in favor of dermatitis herpetiformis. In terms of treatment, 2 important things. Number 1, gluten-free diet. And the drug of choice for this condition is Dapsone. We become the next topic on infections. We had 3 important questions from the topic of infections. First question, a 48-year-old patient, asymptomatic lesion on the right cheek with central atrophy, which has been slowly progressive. So we see this plaque, which is slowly progressive, and there is central atrophy here. Okay, you can see there's a central atrophy. Since the last 2 years, chest X-ray shows apical calcification. So we have a slow-growing plaque-like lesion on the face with apical calcification. This is going in favor of lupus vulgaris, because lupus vulgaris shows central atrophy plus scarring, periphery shows extension. Now, lupus vulgaris is a form of cutaneous tuberculosis. How do you confirm the diagnosis? Mantoux test is not confirmatory. It just tells us about the immune response. Slit skin smear is performed in Hansen's disease, so it cannot be the answer. Probe test is generally used to look for rather bone involvement to rule out osteomyelitis, so this is not the answer. The correct answer for this question is option number A, PCR. Quickly looking at tests which are used for the diagnosis of cutaneous tuberculosis. Number 1, the test which can detect either the mycobacteria or the tissue changes here. Number 1, we have mycobacterial culture, which is gold standard. Please remember, students, the problem with this investigation is slow results. It takes a lot of weeks for the results to come. And in paucibacillariform, for example, if you consider lupus vulgaris, the load of Mycobacterium tuberculosis is less. So the bacilli is less, so the yield is less. Another important confirmatory test, which is cornerstone for diagnosis, is skin biopsy to look for dermal granulomas. That is because tuberculosis is a granulomatous disorder. To detect the immunological response, we have 2 tests. We have either the tuberculin skin test, the Mantoux test, and as well as we have the IGRA test, which is interferon gamma rays assay. Only to remember that the specificity of the IGRA test is more when compared to Mantoux test. However, please remember, students, both are only for detection of immunological response. Now let us see what is PCR, which is polymerase chain reaction. So this is a valuable test in lupus vulgaris because it can detect the DNA of Mycobacterium tuberculosis. Now, what are the 3 important uses of PCR in lupus vulgaris? Number 1, rapid diagnosis. It's much faster than the traditional culture methods. Number 2, increased sensitivity. I've already mentioned to you, students, that Mycobacterium tuberculosis, the load is going to be less here. So whenever there are scarce amount of bacilli or culture is not possible, increased sensitivity is seen with PCR. And finally, it acts as a complementary investigation to histopathology, especially when the case is undefined. When you're not sure of the diagnosis, PCR is complementary to histopathology. What is probe test? You physically use a probe here, especially in foot ulcers, we use it. What do we do? The probe is pressed against the ulcer base. Suppose it directly touches the bone, that means it is suggestive of a condition called osteomyelitis. That's why we generally perform this test in diabetic foot ulcers. Next question. A 68-year-old farm laborer presented with swelling over the right foot for 2 years. It's asymptomatic initially. Now there is serious discharge with black color granules. Potassium hydroxide mode is performed of the discharge. What will it reveal? Now we have a farmer by occupation presenting with swelling with black granules. So swelling, sinuses, and discharging granules, we are talking about mycetoma. Once there are black granules, straight away we are going to talk about mycetoma, which is fungal. Now, out of the options, arthrospores are generally seen in dermatophytosis. So, in dermatophytosis, like tinea infections, we have arthrospores. Budding is with the pseudohyphae is a feature of candidiasis. Hyphae with flower-like conidia arrangement is seen in sporotrichosis. That's why the correct answer for this question is option number C, septate hyphae of 4 to 5 microns. Mycetoma, based on the etiology, is bacterial or fungal, actinomycetoma or mycetoma. When we look at the triad of mycetoma, we have tumefaction, which is tumor-like swelling, which is generally painless. Then we have discharging sinuses, and then we are going to have granules. And what are these granules? These are colonies of the microorganism. When we subject these grains to direct microscopy, so please remember the fastest way to get a presumptive diagnosis of mycetoma is to do microscopy of these grains. In case of actinomycetoma, what do we get, students? We get gram-positive filaments, which are 0.5 to 1 micron meter. Whereas in mycetoma, we get gram-negative septate hyphae, which measure between 2 to 5 micron meter. So this was what was asked in this time's exam as a question. In terms of treatment, actinomycetoma, we generally use Welch regimen, which is made up of cotrimoxazole and amic acid. So cotrimoxazole with amic acid are the drugs we use in Welch regimen. Mycetoma, we are going to use antifungals. Next question. A child presents with trigeminal neuralgia associated with painful vesicular lesions around the mouth. On inoculation on cell culture, we're going to have multinucleated giant cells with intranuclear inclusion bodies. So when there's a vesicle, MNG cells, intranuclear inclusion bodies, we are talking about herpes group of infection. The correct answer for this question is HSV virus, which produces orolabial herpes. Next, we move on to pigmentary disease. There was one question from this topic. A patient presents with asymptomatic macular lesions since childhood. Diascopy was inconclusive. Woods lamp examination shows white accentuation. What is the most likely diagnosis? Now, how do we approach this question? This question has not been asked before, so let us look at this question. The question says this lesion is there since childhood. And when you see the lesion is on the trunk since childhood, vitiligo can be ruled out, indeterminate leprosy can be ruled out because these are acquired conditions. They're usually not seen since birth or childhood. Okay, with two options gone, we are left with two birthmarks, that is nevus anemicus and nevus depigmentosus. The question says diascopy was inconclusive. In nevus anemicus, diascopy is positive. The correct answer for this question is option number C, nevus depigmentosus. Now, most of the students got this question wrong. They marked it as vitiligo simply because they saw this white color on Wood's lamp. Now, please remember, white accentuation can also be seen with nevus depigmentosus. The only way to get this question correct was the onset of the disease. The onset of the disease was childhood, not an acquired condition. That's why the answer is not vitiligo. The correct answer is nevus depigmentosus. Now, what is nevus depigmentosus? Also known as nevus acromicus. It's a congenital non-progressive hypopigmented macule. It is generally stable. That means it doesn't increase in size. And usually it is a single lesion, can have serrated borders, which was not very well appreciated in the exams as per as the feedback, but generally does not cross the midline. It is generally segmented. How do we distinguish nevus depigmentosus from vitiligo, students? Number one, this I already mentioned, congenital, vitiligo is acquired. Nevus depigmentosis is a stable condition, vitiligo is progressive. The melanocyte numbers are generally normal in nevus depigmentosus. That is because the problem here is defective transfer of the melanosome from the melanocyte to the keratinocytes. Whereas in vitiligo, there is destruction of the melanocyte because of an autoimmune process. That's why the melanocytes are absent in vitiligo. On Wood's lamp examination, nevus depigmentosus, you get off-white accentuation without fluorescence. So please remember, off-white accentuation, there's no fluorescence here because melanocyte number is normal. Whereas in vitiligo, you get accentuation with milky white or blue white. So different sources mention milky white as well as blue light fluorescence. So this white was a distractor for many students. So please remember, off-white accentuation without fluorescence is nevus depigmentosus. Vitiligo will have accentuation of the color with milky white or blue white fluorescence. Now, what is nevus anemicus, students? Now, please remember, nevus anemicus is a congenital white patch of vasoconstriction. So, please remember, whenever there is vasoconstriction, there is decreased blood supply. That's why it is a vascular anomaly. Now, what will happen if you do diascopy? Diascopy is a test wherein you take a glass lens and test the lesion. Now, in nevus anemicus, there is already vasoconstriction. Now, what will happen if you perform a diascopy test? The surrounding normal skin around the patch will blanch. And once it blanches, what will happen? There's a blanching response, means the blood supply from the normal skin is squeezed out, due to which the margin of nevus anemicus will blend with the surrounding skin. So this is called as positive diascopy. So once again to repeat, in nevus anemicus, there is vasoconstriction. When you perform a diascopy, what is happening? The surrounding skin also will blanch. That time the margin of nevus anemicus is going to fuse with the surrounding area. That's why diascopy is positive in nevus anemicus. This is the test that we use to clinically distinguish between nevus anemicus and nevus depigmentosus. So if the question says in relation to hypopigmented lesion, if diascopy, if it says negative, That means the cause of hypopigmentation is non-vascular. It is not vascular, it is not nevus animicus. Let's move on to the next topic on nutritional dermatosis. A 8-year-old girl presented with follicular hyperkeratotic papules over the elbows, knees, and buttocks. So here we can see the follicular hyperkeratotic papules over the elbows in the image. She also has dry skin, which is xerosis or xeroderma, and lusterless hair. So hyperkeratotic follicular papules over the extensors is referring to phrenoderma. Phrenoderma is also known as toad skin, which could be a manifestation of essential fatty acid deficiency or vitamin A deficiency. In the context of vitamin A deficiency, the next step, what I would want to do is I would want to perform an ocular examination to look for vitamin A related deficiency signs. So the answer is option number D. So what are the different vitamin A deficiency related eye changes? Number one, we could have nyctalopia or night blindness, which is more of a symptom. We can look for conjunctival xerosis and Bitot spots. These two are conjunctival changes. Under cornea, we look for corneal xerosis and keratomalacia or corneal ulceration. So one symptom, two features in the conjunctiva and two features in the cornea. We move on to the next topic of genodermatosis. A patient presented with photosensitivity, freckles on the face, upper arms and the chest, and history of two basal cell carcinomas. So there's photosensitivity, there's freckling. Freckling is basically a condition where melanocyte number is normal, but the activity is more. So you get multiple hyperpigmented lesions here. And there are two basal cell carcinomas. That means we are discussing a condition, students, which is autosomal recessive in nature, and it has a high chance of developing skin malignancies. We are talking about xeroderma pigmentosum. So what is the pathology in xeroderma pigmentosum? It is the nucleotide excision repair mechanism which is inward. Though this mechanism usually removes all the damaged DNA which is damaged by the sunlight. So once this repair mechanism does not happen, the damaged DNA continues in the genome, produces genomic instability and photocarcinogenesis. We take up this one question from STI. So surprisingly, students, this time we didn't have any proper question from STI, which is very, very surprising. Usually we get one question from genital ulcer disease, two questions from genital discharge syndrome, either a urethritis or a vaginal discharge or a syndromic management question. This was very, very surprising this time that we didn't have a proper question from STI. So for the purpose of discussion, I've taken up this question. A 30-year-old young man presented to the clinic with recurrent history of disseminated gonococcal infection. Cultures of urethral discharge and synovial fluid from the knee shows growth of Neisseria gonorrhoeae. Which of the following immunodeficiency is seen? Now, obviously, gonorrhea is discussed in dermatology, but usually what we do, we discuss only gonococcal urethritis. So where could a question like this be sorted out by students is when you learn microbiology, you look at the complement system. And when you read the complement system, we have something called as the membrane attack complex. So in disseminated gonococcal infection, the deficiency is going to be of the complement components C5 to C8. So the correct answer for this question is option number A, deficiency of complement. So I just thought we'll discuss this topic, disseminated gonococcal infection, because repeatedly in the exam we're getting questions from gonorrhea. However, this is going to be a new question. So disseminated gonococcal infection is seen in 0.5 to 3% of patients of gonorrhea. Here what is happening, there's a bacteremic spread of Neisseria gonorrhoeae and it is associated with complement deficiencies of the membrane attack complex C5b to C9. There are two important clinical syndromes where the patient presents. Number one is called tenosynovitis dermatitis polyarthralgia syndrome. And number two, we can have purulent arthritis syndrome without any skin lesions. When we look at the first one, the tenosynovitis dermatitis polyarthralgia syndrome, it is usually seen 2 to 3 weeks of the primary infection. And here what is going to happen, you get tenosynovitis, very, very important feature. You get multiple tendons simultaneously which are involving the wrist, fingers, the ankles and the toes. This dermatitis and this polyarthralgia without purulent arthritis. When we look at the skin lesions, it is seen in 75% of the patients can have skin lesions. Happens due to bacterial embolization and cutaneous microabscesses. The characteristic skin lesion here is acral hemorrhagic vesicles of pustules, which is very, very characteristic. So acrally distributed hemorrhagic vesiculopustular lesions are suggestive of DGI, disseminated gonococcal infection, usually seen at the distal extremities, Please remember these are very transient lesions, and 3 to 4 days, even without treatment, they will disappear. So when should a clinician suspect disseminated gonococcal infection? So this is very, very important, especially an orthopedician is likely to see these cases. A sexually active adult, less than 40 years, multiple partners, males having sex with males, MSMs, it's very, very common. If a patient like this presents with arthralgia or joint pain, with accompanying skin lesions, those vesiculopustular hemorrhagic lesions, and tenosynovitis, then we should think of DGI, disseminated gonococcal infection. What investigation we should do? Number one, you look for synovial fluid for culture. It can be positive only in 50% of the patients, generally when there is purulent arthritis. And you should take specimens from mucosal sites like urogenital, rectal, and pharyngeal specimens, and you look for Neisseria gonorrhoeae. Let us now look at some overlap topics. Who is covered under the POCSO Act? So, Protection of Children Against Sexual Offences Act. So, this basically covers a child less than 18 years. How is it related to dermatology? Because we have dermatology, venereology, and leprosy. So, under venereology, we often get children with abuse who can have an STL, like genital warts. So, every dermatologist knows about the POCSO Act. Hyperpigmentation in Addison's disease happens because of increased ACTH. That was the answer. Then there was an MCQ talking about diffuse skin thickening, anti-SCL70, and this is referring to diffuse cutaneous systemic sclerosis. A strong association of diffuse cutaneous systemic sclerosis is ILD, that is interstitial lung disease. So with this, we conclude the discussion of the dermatology questions.